Welcome back to part 2 of chapter 13, the peripheral nervous system and cranial nerves. So we are picking up where we left off, but we're going to going into a little bit of pathophysiology of the peripheral nerves and then into cranial nerves. So there are multiple ways that axons can be injured. I've already talked about the idea of diffuse axonal injury in case of shear stress, that is a concussion, a diffuse axonal injury. But you can also have issues of ischemia and other things that can lead to degeneration. For instance, compression. For instance, if you have an inflamed tissue and the muscle is inflamed, or the connective tissues, or the meninges can be inflamed, then you get a compression type situation. And the combination of compression and ischemia in that patch of the membrane can lead to axonal degeneration. You can have autoimmune disorders or viral disorders, polio, Guillain-Barré syndrome, ALS, multiple sclerosis. All of those are demyelinating situations. You can have overt disconnection. That can be due to blunt force trauma or penetrating trauma, or there is some evidence of spontaneous degeneration as well. So here are the kind of steps that we go through if we are able to generate or regenerate an axon. Following an injury, you're going to have some inflammation. You are going to have some fragmentation of the original tissue. Well, that needs to be cleared out. And so what will happen is macrophages will actually come out of the bloodstream in a process that is actually used by cancer cells to invade other tissues in metastasis. Those macrophages will extravasate out of the blood vessels and into the tissue in order to absorb, phagocytose is the word, or otherwise break down any dead or debris, if you will. Then the Schwann cells will then send out signals that will then cause the regeneration to occur. You get these sprouting filaments out of the axons. Pretty amazing process. And regeneration of the myelin sheath, courtesy of the Schwann cells. So again, if this is in the peripheral nervous system, in the central nervous system, you have oligodendrocytes, which behave differently. And scientists are working hard to figure out the reasons why. One of the most common forms of demyelinating disorder is multiple sclerosis, a multifactorial, multigenetic syndrome that manifests as this sort of autoimmune chronic demyelination syndrome. And we call it a syndrome because the symptoms do vary. What we do know, or we have a pretty strong feeling about, is that the immune system no longer recognizes the myelin sheath in the central nervous system, not the peripheral, as self. That is self versus non-self. And so what happens is these antibodies begin attacking the myelin, degrading it. It's in the CNS, and if you remember from the last couple of slides, the CNS is much, much less able to remediate axonal injury due to the fact that you have oligodendrocytes and astrocytes versus Schwann cells. And that in and of itself seems to be part of the problem with multiple sclerosis. Again, one of the most common demyelinating disorders, and it's progressive as well. It usually strikes people that are relatively young, mostly female, almost 200,000 cases per year in the United States, and there really is no going back from it. The only thing we can do, we have what are called DMARDs, disease modifying reagents, drugs. But what happens is you start to see loss of the ability to signal. Instead of a saltatory conduction, which is very, very fast and jumps from node of Ranvier to node of Ranvier. Now you've lost that insulator, and the signal may not have enough strength to make it to the next node because of current leak. Now that you've lost the insulator, there is unwanted or unregulated exchange in that axon. And so a signal that may have originated from a node of Ranvier here may weaken and die before it can get to the next node where the appropriate infrastructure for creating an action potential exists. And so what do you see? You'll see loss of vision. You get numbness or occasionally tingling, muscle weakness, often leading to more severe paralysis, changes in reflexes. Why? Because you have the afferent and then the efferent. Changes in body position and the ability to walk. So what do we try to do? We try to slow that inflammatory process, and the generation of antibodies stems from inflammation. So the inflammation is a non-specific response, but if you develop antibodies, that's a specific response. So we're going to try to use things to slow, first of all, the inflammation and or production of those antibodies. Steroids are quite common for this. They are immunosuppressants. They'll use supportive equipment and physical therapy, any number of, depending on the loss of function, then you will try to remediate that as best as possible. But the single most effective treatment is prevention. So the DMARDs, if you will, the disease-modifying anti-inflammatories. And it's variable. It depends on the severity. It depends on, because again, it's a multifactorial disease. It may involve multiple genes. Some people may have problems in the genes, some may not. It may be occupational exposure in some cases. We just don't know yet. And so we're still relatively naive about the best way to deal with this. Another very well known but not fully well understood demyelinating disorder is called amyotrophic lateral sclerosis, ALS. Sometimes you'll hear it as Lou Gehrig's disease. Lou Gehrig was a famous first baseman for the New York Yankees. He played alongside Babe Ruth and was part of the famous murderer's row of batters in professional baseball back in the 1920s. There were 6 guys on that team who could just crush the ball. And Lou Gehrig held the record for grand slams. He also held a record for playing 2,130 consecutive baseball games without missing a game, which is, if you did it every day, that would take you over 6 years to accomplish that. So he was known as the Iron Horse for his durability and his batting ability as well. But he did succumb to the disease, and he had one of the most famous speeches in baseball on the day that he retired. Another famous person that you might have heard of, he's newer. He rose to prominence in the 1970s as a mathematician who suffered from a sort of a long-term ALS. It progressed early in his life and then stabilized. And he actually credited his career on his condition because he said he would have never have been disciplined enough to spend the time thinking about the things the way that he did. He became an expert on black holes. He was an astrophysicist and did some amazing work without having the ability to use his arms because of his condition. But it was a long-term stable form, whereas Lou Gehrig suffered from sort of a rapidly progressing version of it. So it's progressive, though not always. Hawking is an example of where it's stabilized. It's neurodegenerative, and it starts out in the peripheral nervous system, motor neurons, and moves upstream. So it will move more and more, and to the point where the motor neurons that control breathing become affected, and the patient basically dies because they no longer breathe. Usually happens in middle-age years, 40 to 65. Coach at my undergraduate college, he succumbed to it There does seem to be some genetic component, and because it's progressive, people generally succumb within 5 years. Hawking lived with his for decades, for 35 or 40 years. He finally died almost in an accidental way not too long ago. Symptoms start with loss of coordination. So Lou Gehrig started struggling and unexplained reasons why, and slurred speech, cramps, loss of motor function. There are some growing treatments for it. You're trying to block certain things, but at this point, we just don't have a good handle on it, and that's why the fundraising, like from the National Football League and so forth, has helped tremendously in leading us towards a better understanding of this demyelinating disorder. Another disease which not only has had implications in the past, now seemingly may have some implications in the future, and that is called poliomyelitis. Now, this is not a demyelinating disorder. This is actually an outright cell death disorder. It's caused by a viral infection that affects the lower motor neurons and the reason viruses will affect one cell or another depends on what's on the surface of the cell and what's on the surface of the virus. In this case, the virus seems to be somewhat specific for these lower motor neurons and the cell bodies in particular. So they in the ventral root, the virus spreads quite easily. It's very, very contagious. There are some famous people that you might know of. Franklin Delano Roosevelt, who was the president of the United States during the end of the Depression and World War II. He's the only president to have served more than 2 terms. But in any case, he came up with what appears to be a sort of adult onset version of polio, though many people suspect he rather had Guillain-Barré syndrome, which would look a lot like polio. Nevertheless, if you've heard of the March of Dimes, the March of Dimes was a charity designed to raise money to help treat polio victims, and there were thousands and thousands in the United States alone. And one of those thousands of children ended up becoming one of the most powerful congressmen in U.S. history. He was the Senate Majority Leader when the Republican Party was in majority, but he would be the Minority Leader when the party wasn't in the majority. But he served in that role for decades, longer than any other senator in U.S. history. And he was a polio victim himself. And so polio was widespread. It's extremely virulent and hard to contain. So you normally see it under children under 18, most under 5 years of age. If you've heard of an iron lung, what happens is these patients get to be so severe that they have to be respirated manually. And so an iron lung was quite common in the 40s, 50s, and 60s until the advent of the vaccine. The symptoms are just look like general malaise, just like anything else. The problem is, though, that the muscle weakness ensues, and then you have paralysis to the point where you may stop even breathing. Some will recover from it. Many will not. The best treatment we know of is vaccine. And because of the success of the vaccine program, that polio was all but eliminated in the United States. There are still examples of polio around the world, and that's the big problem with refraining from continuing to vaccinate, is that it could make a resurgence, just like measles. So healthcare providers are actually extremely concerned about the vaccine denial wave that seems to be passing through our country at this time. Next, we move into the cranial nerves. We have 12 pairs of them, so there's 24 total. These nerves arise from in and around the brain stem or right in the area of the diencephalon. And they have either purely sensory, purely motor, or they are mixed. We do have 4 categories. Now, this is an exercise in brute memorization. So please do look at the text, page 499 to 506, and try to do your best to get these down. As far as the lab exam is concerned, I'm going to go with um, not quite such specific anatomical things as perhaps functional or notable things, rather than you being able to recite any and all of them and their so forth. But there are ways to memorize these functions, and we're going to try to show you those. So the purely sensory ones, this one's pretty easy. The olfactory and the optic, 1 and 2, are purely sensory. They do not have any motor function whatsoever. Then we have purely motor functions, which is 3, 4, 6, 11, and 12. All right, 3 and 4, 6, 11, and 12. Then the mixed. Now, my favorite one of the mixed is actually the vagus nerve. All right, they call that vagus because it's the wanderer, cranial nerve 10. And then you have some that are purely parasympathetic, 3, 7, 9, and 10. And the vagus nerve is in that parasympathetic pathway. It's also a mediator of things called referred pain and some of those things. But again, stay with the text here and do your best. Stay tuned here in the next slide for some mnemonics. There are several, and you could even invent your own if you wanted to. Oh, 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 to touch and feel very good velvet. All right. Ah, that's a really good mnemonic. And again, you have to match olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, and spinal accessory / hypoglossal. There are other ones that are maybe less famous, or again, you can come up with your own. An old Olympus towering top of Finn and German vaults. Okay, whatever. Once one takes the anatomy final, very good vacations are heavenly. That one seems to fit a little bit better. On occasion, our trusty truck acts funny. Very good vehicle anyhow. I don't like that one. I think the middle one works really well. And I do like this one over here. As far as the second mnemonic is around, this one I think works best far and away. Some say marry money, but my brother says big brains matter more. That is sensory, motor, and then both for mixed. So you use both here as opposed to mixed. So you can get rid of that M and you have a B there. So you have two mnemonics. You have the mnemonic of the name and you have the mnemonic of the function. As far as lab practical is concerned, what I would do is I would either give you the function and the Greek and the Latin number, and then you would have to come up with the name, or I would say, here's the name and number, and you come up with the function. All right, you see how I do that? I will give you at least a toe hold that allows you some hint as to what it is. So I try to do it that way, given that we are a relatively low level course, but nevertheless, you do kind of have to power through this. It's a tradition. It's a rite of passage. You have a mnemonic for the name, and you have a mnemonic for the function. And this slide is just more of the same, though it shows you some of the breakout of why, olfactory is smell, optic is vision, whether it has motor function, and whether it's parasympathetic. All right. A lot of the parasympathetic functions come out of the cranial nerves, particularly the vagus nerve. Okay, big time. All right. Some other ones as well. And this is why they say the body doesn't lie, because many of the signs, and in fact signs that gamblers will use playing poker, they call them tells, are actually autonomic responses. People even get to the point where they will look at the pupils of the eye, and that's why many poker players will play with glasses on for that reason, so that it's harder to see the dilation and constriction of the pupils. And so they train to try to suppress the autonomic functions. But in any case, here's a little more of a detailed chart if it helps you. Again, we're going to focus on name associated with a given Latin number or function associated with a name in Latin number. What I cannot do is speak to what the written test material is. And that's the one thing that I don't want to scare you, but that's one reason why I would give you instructions about the practical, but I can't give you instructions about the written because I do not see those questions. So we have several slides here talking about some of the basic functions of these neurons, which Roman numeral they are, what their name is, and what their primary function is above, beyond sensory, motor, and mixed. I wish I could give you more guidance on it. I would just say the more you know, the safer it is. But remember too that you have a lot of other information. Try to get at the big ones. Try to get at the simple ideas. And in some cases, these things actually give it away. Olfactory means smell. Optic means vision. Oculomotor, we're working eye muscles. Trochlear, a little harder. That's eye muscles again. Maxillary, that's the skin of the face. Oral cavity, that's the maxilla bone. The mandibular, all right, the motors of chewing. Facial, these things do. Vestibulocochlear, that's the organ that is involved in hearing and balance. So there are some things here that can sort of lead you. Vagus goes all over the body. It's the wanderer, so it's got mixed function, primarily down into the digestive tract. And you can see the pharynx as well. Okay, so you can at least cover your bets. You don't have to memorize this ad nauseum, but if you have a few hints or there, can you use a mnemonic? Can you do something along those lines? I think you'll be okay. Here's a superficial image of the cranial nerves. You can see they sort of move. The numbering goes from shall we say more ventral to more dorsal. You could almost say it's three-dimensional, so it's actually moving down when you get down into the spinal, the brain stem. But in any case, it's sort of forward to backward in terms of the numbers. And finally, a view of the brainstem relative to many of these cranial nerves. Again, I wouldn't show this image as far as lab practical. It is theoretically possible that a brainstem might show up. I don't know. I can't speak to the written. Your best bet, though, is to get the name, get the Latin number associated with that name, and the basic functions, either sensory, motor, mix. That's a mnemonic, and then try to use the names of the neurons as to sort of divine basic function. Good luck with that. I know I would do it slightly differently, but this is the way the course is, and there are reasons why we would do it this way. So, and that is to make you stronger, more capable caregivers. And so this does it for the Chapter 13 lecture. Thank you for your time, and as always, please bring your questions to class or email, and I'll be happy to answer them as best I can. Thanks again. Talk to you soon.